Hello, everyone. On behalf of the National Alliance for HIV Education and Workforce Development, also known as NAHUD, I would like to welcome you to our monthly webinar series and thank you for participating. Before we begin, I would like to review some housekeeping items. We invite you to use the chat to engage with your fellow attendees. I have added a chat waterfall, and we do ask that you add your name, your organization, and we have a question for you. Can you guess what is in Dr. Fry's background? Today's session is being recorded. The session recording and a PDF of the presentation slides will be added to NAHU's webinar website as a resource. You will receive the information in the post-webinar email that will be sent out through Zoom. You can also visit NAHU's resource page on the website to find this resource and view the past sessions. Throughout the session, please use the Q&A pod to ask your questions. The speaker will address them at the end of the presentation. If there is time and you would like to ask your question live, please raise your virtual hand and I will open your line to speak. So just some background on NAHUD for those who are not familiar. NAHUD is a membership organization of 8 regional and 2 national AIDS education and training centers, also known as the AETCs. Established in 2010, NAHUD supports the AETCs, a component of the HRSA-funded Ryan White HIV/AIDS program, which have an explicit directive to build and maintain a well-educated and culturally sensitive health professions workforce that can provide prevention, diagnosis, care and treatment, and medical management for people at risk for and living with HIV. NAHU collaborates with multiple organizations to promote and educate on the work of the ATC program. Since 2018, NAHUD has been funded by the American Academy of Addiction Psychiatry as a partner organization of the Opioid Response Network to address the intersection of HIV and opioid use disorder. ORN was created to support efforts in addressing the prevention, treatment, recovery of opioid use disorders, and other substance use disorders through the provision of locally designed education and training. We welcome you to visit the website to submit a TA request, read case studies, see featured resources, check out upcoming ORN events, trainings, learn about ORN work groups, addressing health disparities, and more. And I will enter that after this introduction. We'll enter the website for ORN in the chat. We value and welcome your feedback on today's webinar. We will include a link to the evaluation toward the end of the session, and it will also be included in the post-webinar email that you will get tomorrow. Please complete it within the next 2 weeks. Once the survey is closed, we are unable to reopen it. If you are requesting CE credit or a certificate of attendance, you will need to complete the evaluation. So again, we are offering CME, CNE, social work, and again, a certificate of attendance. To receive contact hours for participating in the continuing education program or the certificate of attendance, the registrant must join the webinar. So if you are in a group, we're happy that you're all here, but if you can get to your own computer so you can register so we can document that you're attending today, that would be great. You must also attend at least 60% of the scheduled program and complete and submit the electronic evaluation. You will receive your requested certificate within 3 weeks of submission of the evaluation. So without further ado, I have such a pleasure of introducing today's speaker, Dr. Liz Fry. She is an internationally recognized expert in street psychiatry and has worked in the field for the past 16 years. With her medical and public health background, Dr. Fry developed strategies for addressing mental health and substance use disorders among unhoused people at a population health level. Dr. Fry previously founded and directed Atlanta's first street medicine program. She has also worked to integrate behavioral health into the AHN Center for Inclusion Health Services, including street medicine in Pittsburgh, Pennsylvania. Dr. Fry holds a medical degree from the University of North Carolina and a master's in public health from Emory University. She completed residency and a community psychiatry and public health fellowship at Emory. Dr. Fry serves as the chair for the Street Medicine Institute's board of directors and has led the Institute's annual International Street Medicine Symposium since 2017. So again, without further ado, I would like to hand it over to Dr. Fry.
Hi, everyone. I'm so glad that you all could make it today. I'm going to go ahead and pull up my slides and get started here. All right. Oh, it disappeared. Hold on one second. There we go. All right. Somebody tell me if you can't see my slides full screen. So, I am talking about HIV and substance use disorders today, and kind of how we think about those. How we think about innovating services for people who are sleeping mostly outside. And for the purposes of this talk, I'll say things like people sleeping outside, people who are sleeping rough, rough sleeping. That all means unsheltered homelessness. Um, I don't receive any funding or support from commercial entities or even grants. I do have a book which I will reference, and the royalties from the book go directly to the Street Medicine Institute, and I'm a fiduciary of the institute. So roundabout, sort of, I do benefit from talking about the book, but only by helping keep the Street Medicine Institute afloat. And the royalties are not enough to keep the Street Medicine Institute afloat all by itself. Okay, so my computer will participate here. The objectives for today, we're going to talk about core values of street medicine, and thinking about how we do prevention and treatment for people who have HIV and people who use drugs, who are living unsheltered. We're going to look at some of those kind of public health prevention strategies, both primary, secondary, and tertiary. And then we're going to think about how some of the adulterants in the current street drug, like contaminants in the street drug supply, can reduce people's ability to attain their goals in terms of substance use and HIV. Okay, so I just want to say that there was a webinar back in November that Brett Feldman did about street medicine for you all. If you haven't, and that was a much more kind of comprehensive look at like what is street medicine, what is our core values, things like that. So if I'm glancing over some of those things, you can, and you want more detail about them, you can watch his recorded webinar or look at his slides. I highly recommend that. But I always like to start out a talk about street medicine by saying, what the heck is street medicine? And so what it is that we're going out to people who are sleeping outside in their encampments, under bridges, in the woods, wherever, and we're providing health and social services that specifically address their needs in their own environment. And I like to use this kind of this picture from National Healthcare for the Homeless that really aptly kind of describes the continuum of what street medicine and kind of mobile medicine, et cetera, looks like. And so you can see it's on the spectrum. Not one's not better than the other. They both serve different needs, and you have to address the needs of a variety of people experiencing homelessness in order to really adequately address health and morbidity and mortality issues among those people. So street medicine on the farthest end of the spectrum is folks getting out of their vehicles, wearing backpacks, going to the people wherever they are, and providing care in the encampment, in the tent, in the, by the river, in the person's own environment. And that distinguishes it from any other kind of care. Maybe you take a truck around and you see people either in the truck or next to the truck. They have to come out from their encampment to engage with you at the truck. You're not in their environment, so it's not exactly street medicine. Similarly, if you drive a mobile coach and or if you have a Sprinter van and you go park it somewhere and people come to you for care, it's not street medicine because you're not in their own environment. You're closer to their environment, but you're not in their own environment. And one is not better than the other, like I said, but it's really important to distinguish what street medicine is, because a lot of times the closer you get to the mobile unit side, the less you are able to adequately address the health of people sleeping outside. The folks who I treat out on the streets are going to be the ones running away from the mobile unit. Okay, and then just to further kind of codify this, a couple of years ago, CMS agreed to create a place of service code for the streets. So now it used to be that anything you did inside four walls or inside a mobile coach or things like that, but it kind of had to be within four walls, you could bill for from a medical standpoint, but you couldn't bill for doing that same work out on the streets. And so the place of service code 27 is defined as a non-permanent location that, hold on one sec. Okay. Or found environment that's not described by any other place of service code. So it's not a mobile health coach code because that has its own code, and it's not a shelter-based clinic code because that has its own code. It's where health professionals provide prevention, screenings, diagnosis, treatment, etc., to people living unsheltered. Okay, so this core values part is particularly what Brett Feldman talked about in the webinar in November about our core values. And first up there, I think I probably drilled this in enough, but the most important thing is that we're going to the people wherever they are. We're not asking them to come into our space because our space is oftentimes threatening. People have experienced a lot of harm and trauma from healthcare providers in healthcare settings. So we're going to the people where they feel safest. We're working on really like probably every single visit, we're working on building trust. And even if you've known somebody for 3 years, you're still out there on the street working to build trust with them. It involves a lot of solidarity. And that, like, we think about that in all different kinds of ways, but essentially, we're going to be the ones that are sitting with people in the hole that society has dug for them, and they've been sitting in there and they can't get out of it and they can't get out of it. We're going to go in that hole with them, and we're going to be in solidarity with them to help them figure out how to get out of the hole. We can get out of the holes ourselves because we have ladders and things like that. But, once folks who have nothing get in that hole, it's really hard to get out without themselves. And it's different from a charity model where we're sort of still on the outside but reaching in. We have to go in deep and be with people where they are in order to help them figure out their own way out. That gets into the idea of patient-led care. We hear a lot about patient-centered care, but what we really care about in street medicine is that we not only want to flip that like medical hierarchy on its, I think flipping it on its side is sort of patient-centered care. But what we want to do is flip that reality completely upside down, and we want the patient to be in charge of the care that we're giving. That doesn't mean that we're going to do things that are, medically unethical or unsafe or things like that. But we're going to let the patient take the lead in telling us what's most important to them, and we're going to start there. Radical humility, I think, is another core value that we really have to keep in mind for ourselves. I think certainly as a physician, but just in general in the medical system, it teaches us that we know it all, and that our patients don't. And we're there to kind of stand on high and tell people what they need to know. But really, the reality, and especially for people sleeping outside, they know what they need. They just need us to help provide resources. And the work that we do in kind of shutting down our kind of ego in these things is just to go in with a lot of humility and to say, even if you did nothing wrong, to apologize for all the wrongs that the healthcare system and other systems that were supposed to care for people did wrong. And then there are words that the federal government does not allow me to use in this presentation, so I won't use them, but a key goal in terms of and core value for street medicine is really reducing risks that come with sleeping outside, reducing risks that come with substance use, and preventing further harm related to those risks. So just a few universal truths in street medicine that I think, if you're going to go start working out on the street, or even if you're working in a clinic with people who are sleeping outside, it's important to understand these at a very deep level. 100% of the people sleeping out on the street have had traumatic experiences. Frequently, those traumatic experiences started in childhood. If you're familiar with the ACEs study, the Adverse Childhood Experiences study, there are so many things that our folks sleeping outside kind of tick off in those boxes that started in childhood. But by the fact that they are sleeping unsheltered in and of itself is a traumatic experience. And so what we can expect is that we're working with a highly traumatized group of people. And one of the things that, and I've said this already, but one of the things that helps overcome trauma is relationships. And so more than anything else that we're doing out on the streets, more than any kind of care that we're providing, is that we're just sitting and being with people. And we are working on building those trusting relationships. And in that way, we're going to hopefully make better the distrust that our patients have in most healthcare workers and even outreach workers who make lots of promises but don't fulfill them. We're going to make almost no promises, but we're going to work hard to fulfill every single promise we make. So that also means you can't make promises you can't keep. Another universal truth in street medicine is that pretty much everyone has that trimorbidity, at least among the people that we're working with in street medicine who are sleeping outside. And the trimorbidity it's the trifecta of having a physical health problem, a substance use disorder, and a mental health diagnosis. And what we can see is that when people have this trimorbidity, their health is sort of exponentially worse than people who just have kind of two of those components. And then most of the time when we're meeting people out on the street, we're meeting them in advanced stages of their illness at that first visit. And there's a lot of research going into kind of show accelerated aging in different populations. There's a researcher out in LA at University of Southern California. She works with the street medicine team there. She has specifically studied accelerated aging in unsheltered populations. And then you all probably know that the unsheltered population, more and more people who are older become homeless for the first time above the age of 65. That's happening more and more and more. So very fragile, very vulnerable population. Okay, so just some like basics in street medicine care, and this is how street medicine should be. There may be street medicine teams that aren't behaving in this way, but this is like this when we at the Street Medicine Institute teach people about doing street medicine, these are the things that we're talking about. And so people who have lived experience of homelessness are absolutely vital team members. They are the ones that are going to know where the encampments are. They're going to know how to interact with folks in a way that the rest of us probably will never be able to or know quite in the same way unless we've had that experience. And they're going to tell us what works and doesn't work for people sleeping outside. Um, and they're also going to be oftentimes be the folks who are kind of looking out for everybody's safety when we're at an encampment, because they have those eagle eyes that they know the warnings, the warning signs, and they can help both the people in the encampment living there feel safer, but also make sure that the team is doing things safely because the team may not recognize safety issues. If you're going to go out and do work on the street, you have to be prepared to work with the entire person, the entire body. And what we find is that a lot of folks who, there are a lot of folks who do primary care, and that's what they're trained in. That's what they're used to doing. And the same for nursing and other stuff. You know, nobody's necessarily done kind of any mental health care, but everybody finds themselves doing some amount of mental health care, whether they trained for it or not out on the streets. And similarly, as a psychiatrist, I'm also trying to assess for issues related to primary care, because I can't just treat one part of the body. And it's best when there are integrated teams of primary care and behavioral health. And both behavioral health and primary care can work towards treating substance use disorders, but it's best when we all work as one team and we all work with the same patients. Another thing, and this isn't true for every street medicine team, but it's ideal, is that we kind of have to care for everyone in the encampment. And now if somebody refuses care, we're not going to force feed them care, right? But we're not able to do, you know, I think there's a risk with that some people see with like health insurance plans getting into street medicine and saying, okay, we'll pay for these people to be seen, but not those people. It doesn't work like that. The health of the encampment requires everybody to be in treatment. And you'll see that in a little bit, particularly when we're talking about infectious disease. Other baseline things for street medicine, I mean, naloxone for everyone. Like, and I don't just mean people who are using, I mean people who aren't using. I mean the like bus driver who sees people you know, at their bus stops, the guy down the street in the gas station store, the mail person. Like, it's all of our responsibilities to recognize and respond to overdose. And so naloxone should be distributed to everybody who wants it, and ideally convince people who maybe don't want it that they need to get it. One other thing to kind of keep in mind as we progress into talking about HIV and substance use disorder care, and this is true for mental health care too, street-based treatment is often safer than clinic-based care. I think that when we get into talking about with kind of health systems, they have this like, oh, the safest place to provide care is indoors in our sterile environment. But it oftentimes it's safer than clinic-based care to see people out on the streets when they're unsheltered. And that's because we can see them frequently. We have a lot of kind of latitude about how often we see the person. There is active outreach that minimizes the number of no-shows. It may mean that we spend a lot of time looking for people we can't find or have a hard time finding, but we're going out and actively trying to find them as opposed to in a clinic. And then there's a lot of like on the ground kind of community level knowledge that, you know, when you can see where someone lives, when you can observe the stigma that that people experience, when you become stigmatized because you're out there sitting next to someone sleeping on the streets, like you understand at a very different level what kind of care that person needs. And so, again, these are just some of the things that should be a baseline part of street medicine care and why street medicine care can be really effective. Okay, so let's shift to thinking about the public health approach. So, as many of you may know, there are public health is all about prevention. Um, and there are these three tiers of it. So, primary prevention is we're going to prevent anything bad from happening. Secondary prevention is that if somebody contracts HIV or contracts, whatever, we're going to detect that early and we're going to start treatment early so it doesn't have the chance to progress and cause worse things to happen. And then tertiary prevention, we're going to prevent complications. So somebody may have had HIV or even may now qualify as having AIDS, but we're going to work really hard to prevent them from getting some of the kind of subsequent infections that somebody might get with having a really low CD4 count. For somebody with diabetes, the tertiary prevention is looking like prevention of amputation and things like that. And then also improving quality of life at that stage. And when we think about where street medicine falls into this, it's at best at tertiary prevention. We are oftentimes preventing people from dying. And if we can't prevent them from dying, we're working really hard to improve their quality of life as they die. And so I can't tell you that street medicine is going to be able to kind of take care of every approach, but we are part of that public health approach. And that's really important. So, just overall, the best prevention strategy for people who are living in a place that looks like this, and this is a photo I took when I was doing street medicine in Atlanta, where people would sleep outside. It's kind of under a bridge. The very best strategy we can do to prevent harm for people living in a place like this is housing. And like, there's no other way to say it. Like, housing helps people, it's virtually impossible to become completely substance free when living in an environment like this. It's really hard to take care of yourself, to be well, to prevent infection from all variety of infectious disease, things like that. It's hard to get your medication. It's hard to remember to take your medication when you're living in a place that looks like this. So housing is the number one prevention strategy. It's also the number one strategy at any level of prevention. But let's talk about primary prevention on the streets. What can street medicine teams do out there that is part of primary prevention? So with relationship to infectious disease, we can give vaccinations to people for Hep A, Hep B. We can vaccinate people for flu and COVID, and things like that. We can also monitor infectious disease in the encampment. So, for example, this is where it's really important to be working with the entire encampment and not just one individual, is that oftentimes the spread of syphilis is huge right now, and it's a major problem among the unsheltered community. And treating one person in that encampment isn't going to help curb the spread of syphilis because people are just going to give it to each other. And so it's really important to treat everyone who has syphilis in that encampment. And street medicine teams are uniquely able to do that. We also can do a lot of work in terms of preventing soft tissue injections, infections that come from wounds, transmission of bloodborne pathogens. Again, this is something I'm not supposed to talk about in terms of what supplies will prevent soft tissue infections and reduce transmission of bloodborne pathogens. But I think you can imagine what some of those things are, and they are still evidence-based. And very important. As a street medicine team, we can also do contact tracing. Oftentimes, we know a lot of people's friends and the communities where they spend time on the street. When COVID happened, the CDC was asking all kinds of street medicine teams to do contact tracing. There have been times when hepatitis A has been a major problem, or tuberculosis has been a major problem in different areas, and the CDC has asked street medicine teams to help do contact tracing because we're the ones on the ground who know. In terms of preventing the spread of HIV specifically, I'm not going to attempt to pronounce the names of these generic medications, but both the medication for PrEP, so that's pre-exposure prophylaxis, and PEP, post-exposure prophylaxis, both of those medications, it's one medication, and we look at giving it once daily because I have enough of a hard time remembering to take pills twice a day. If not, like if I have to take something 3 times a day, I'll like never remember the middle day of the day dose. So I don't expect my patients to do that either. The best thing we can do is offer once daily dosing, and you can with both of these medications. It's important that people can take it with or without food. A lot of times people have a lot of food insecurity on the street and get very minimal calories on a regular basis. It may be that they'll have a single meal of 2,000 calories, but then they won't have another meal that's even 500 calories for the rest of the week. It's not that expensive. Covers a wide range of risk categories, things like that. The long-acting injectables, I think some of you put questions about that when you registered for this webinar. In talking with street medicine, so I'm a psychiatrist, so I don't prescribe HIV meds on the street, but in talking with several different teams that do provide HIV care and PrEP, they've had a lot of people be not so interested in long-acting injectables for PrEP and for HIV. I would say in general, most people don't really like the idea of a long-acting injectable. The most experience I've had with folks on the street is in terms of long-acting injectables for psychosis. And those are also, like, I find that people are most interested in them when their meds are stolen, they can't take the medication regularly, their encampment gets swept and their meds get taken too. And they're just tired of like feeling the way they do without their medication. The thing is with schizophrenia, if you don't have your medication, it's people tend to be really bothered by those symptoms, right? Whereas if you're taking a long-acting injectable for PrEP, there isn't as much sort of incentive because you don't notice anything happening whether or not you're taking the PrEP. Okay, and then primary prevention for substance use disorders on the street. Like, frankly, once they get out to the streets, like there are plenty of people who end up on the streets who do not use drugs. And there are plenty of people who use drugs and subsequently end up on the street. But once people get out to the street, it's really hard not to use drugs. And some of the reasons are practical, like I need to stay awake at night to protect myself, and things like that. So honestly, I think the thing that we can do most to prevent people from developing substance use disorders, if they don't already have one by the time they reach the streets, is housing. And then I think the other thing is treating mental health disorders on the street. And I would include ADHD in that. Because if people are using because they're depressed or they're anxious or they're, their ADHD is untreated, things like that, then you want to try to, address the thing that's causing the use. And so treating the mental health disorders, both with medications and with therapy, is possible out on the streets. And I personally have found that I've had a number of patients who had ADHD, were using methamphetamine, and did really well in minimizing their methamphetamine use because I treated their ADHD with approved stimulants used to treat ADHD. It's highly effective. Okay. Secondary prevention on the street. This is where the person already has the illness, but we are trying our best to not cause further harm. So we're doing rapid screening HIV tests with everyone. Also, most people are doing rapid screening HCV tests, which we can also treat very easily out on the street. And then treatment with one medication taken once a day, and it doesn't matter if you have food or not, you can still take it. And then there is, of course, the long-acting injectable that can be given once a month or once every other month. Because we do patient-led care, we don't insist that people take, we don't insist people take medication one way or the other. So if they want to take meds, but they don't want an injection, that's fine. We've got pills you can take. And if they get tired of their pills being stolen or things like that, and are worried about, developing treatment-resistant HIV, then that might be incentive for them to take the long-acting injectable. With substance use disorders, it's treating the substance use disorder. So there are actually a lot of medications out there for opioid, stimulant, and alcohol use disorders. Contingency management, as far as I know, has not been done on in the street medicine setting. I think there are some programs that are trying to start a research study on that. It's challenging in the street environment, but I think a lot of creative professionals are looking at trying to figure that out for street medicine. Motivational interviewing works really well. But, I think it's important to keep in mind that a lot of our patients are not interested in no use or sobriety when they're on the streets. And so I say aim for safer, reduced use of alcohol and drugs on the streets. And it really depends on your patient's goals. So you need to align yourself with your patient's goals. In terms of medications for substance use disorders, I'm not going to go over this in detail, but I do want you all to take note that these are all medications that can help treat these substance use disorders. The book I mentioned at the beginning of the webinar, I co-authored the Street Mental Health Handbook that was published late last year through Springer. And we have a chapter in that book that specifically addresses, one chapter that addresses kind of how you approach substance use disorder treatment on the streets, and then what medications there are to treat those disorders, and like what are the pros and cons, and thinking about how you do it on the streets. Okay, and then tertiary prevention. Like I said, a lot of times on the street, we're working on preventing people from dying. And if we can't prevent them from dying, we're working on being a trustworthy companion that they have on the streets. And so again, we're just having frequent visits to improve and maintain trust, even at that tertiary stage, to try to help improve medication adherence. Some street medicine teams have the ability to go see people every day or every other day, except on weekends, and give the person the medication that they need to take. We also have the ability, when we see people frequently, to do early recognition and treatment of complications. And that includes things like early and frequent wound care. We're going to do antibiotic resistance testing, because it's been found that a lot of folks out on the street have a whole different kind of set of antibiotic resistance than what we might expect in clinic. We're going to prevent those unnecessary ED visits and hospitalizations, but we're really going to try to maximize the ones that are necessary. I think it's more often that the folks we're working with out on the street are not going to the ED when they need it than overuse of the ED. Like I said, I think throughout this, we're providing companionship, solidarity. There is palliative care, and different places in the country do have some hospice care for folks living out on the street. There's a place in Salt Lake City oh, and I'm blanking on the name, but they are a hospice provider for unsheltered folks. And then there are also end of life doulas who are involved in street medicine work. I have not personally worked with any of them, but a companion, to be with a person while they're um, while they're sleeping outside and dying. Okay, last little thing here. I just want to point out that we are constantly dealing with new adulterants that are coming into the street drug supply. Canada has addressed this um, by prescribing what they call safe supply. So they're prescribing things like fentanyl, methamphetamine, stuff like that, so that the person knows that what they're getting is, well, the person and their doctor know that what they're getting is the pure substance and not all of these adulterants. The adulterants really complicate withdrawal and treatment, and like I said, can underline the patient's goals in terms of either cutting back or quitting. We just assume that fentanyl is in pretty much everything when we're out on the streets, and that includes things like cocaine and methamphetamine. And you can use test strips to see if drugs do have fentanyl in them that aren't opioids. And then I think a lot of the country has heard about or encountered xylazine. It is like a horse tranquilizer that's been introduced into the fentanyl supply. It causes a horrible anxiety with withdrawal, and a lot of providers are finding the need to prescribe benzodiazepines to help people, short-term benzodiazepines to help people with that anxiety. And then what we're seeing here on the East Coast more and more is medetomidine. And you may not have heard of this, but it causes a very complex withdrawal because of the way it causes people to have like very fluctuating high and low blood pressure. That almost means that most people getting off of fentanyl who are also needing to get off of medetomidine are requiring ICU treatment. So here in Pittsburgh, in the last year or so, it's been really difficult to do those street-based starts of like buprenorphine because people are going to require the ICU care for the medetomidine. Okay, just some pearls. I think this is kind of one of my last slides here. PrEP and HIV care on the streets in the street medicine setting is very doable. It's very well tolerated. There are relatively minimal side effects. I think somebody put in their questions about in the questions before the webinar about interactions between street drugs and HIV drugs. The ones that I have listed in the slides are ones that have the least amount of interaction between street drugs and the HIV meds. More of the older HIV meds are the ones that have the really unsafe profile with street drugs. We really, I think, like more than anywhere, you just have to use like an absolute zero stigma approach. And I think it's just like, it's sort of like not being surprised or shocked by anything, and sort of a goal of being like, okay, tell me how that works. Tell me what you think we should do to kind of solve this. If you know that you have some feelings about people using drugs or concerns about people selling their buprenorphine, or if you feel uncomfortable around this, that, or the other population, like I think it's really important to kind of check your own bias and just really work hard to develop that zero stigma approach, because we need to be allies in this work. And the only way we can sit with people in solidarity and build the trust that we need to be able to do the work is to have that zero stigma approach. I've said this already, but primary care teams can effectively treat mental health and substance use disorders on the street. More and more street psychiatrists are popping up in the world, but there are still very few of us compared to the number of people doing primary care on the streets. And through kind of just learning on their own, some like attending conferences or things like that, lectures about how to provide mental health treatment. And then also some teams have psychiatrists that they can consult or even see people on the street. Those are all different ways that people are doing it. But my primary care colleagues who do street medicine, they're essentially like, I look to my left, or I look to my right, I look to my left. I don't see a street psychiatrist, so I'm going to take care of what needs to be taken care of. There are a couple of different teams I talked to in preparing for this presentation, and one of the team said, if you haven't figured out how to do this already, you really need to figure out how to draw labs on the street before you launch into doing PrEP and HIV care, because there are some labs that need to be done. And different people do it in different ways, but the team that I worked on in Atlanta, we had sort of like a cold pack that we carried, and any blood samples we put in that cold pack, and then our nurse had the ability to spin the blood within a couple of hours when we got back to clinic, and so that's how we managed it. And then I think the last thing, and this is just what street medicine is about, is we're empowering people to take care of themselves and each other out on the streets. And that empowerment, giving choice, giving options, sort of, you know, being in solidarity with people, but allowing them to make their own choices, I think is a really key part of being successful in the work. Okay, so here's some resources for you. We have the Street Medicine Institute, which I'm on the board for. USC Street Medicine has some good information, as does National Healthcare for the Homeless. The Street Mental Health Handbook I mentioned, there's a code that you can get 20% off. Street Medicine Echo, which is just a lot of different topics about street medicine, is on the second Monday of every month. And then there's also a Street Mental Health Coalition that meets. You don't have to be a mental health care provider to be a part of that. And they meet monthly on the first Monday of every month. You'll have access to these slides, so you don't have to like rapidly take pictures or anything. There are a lot of things that that I haven't had time to say, or that the federal government doesn't want me to say. So if you have questions related to some of those things, we're going to have some time for questions. But if you suspect I'm not able to answer your question because of those reasons, you are welcome to email me, and I'll be happy to tell you what I, Liz Fry, think. But it's my opinion and my opinion only. All right, I'm going to stop sharing so we can do Q&A.
Yes, thank you so much, Dr. Fry. We're gonna dive right into our Q&A. So to start, this first question, I'm assuming from a team perspective, how do you keep yourself safe, right? So how do you keep your team and yourself safe as you're going to provide these services?
Yeah, so we talk about safety a lot, and it's important. That being said, I've never felt particularly unsafe on the street in the way that I felt unsafe in like an emergency room in the past. Because we go in teams or at minimum in pairs, we're kind of minimizing some of the safety risks there. But I think more than anything, like just the way that we approach the people that we're working with, the like no assumptions, no stigma, aiming for solidarity, building trust, it's those things that promote psychological safety among the people that we're working with. And I would say by far more than anything, I will have people, my patients on the street have told me they will beat someone else up if they try to harm me, than anybody actually trying to harm me. I think when you're also in an open space, it allows for people to just walk away. And then there are times that, somebody might spot a weapon or a gun or things like that. I think if we have seen somebody, it's rare that we've seen somebody carrying a gun out on the streets. But the person on the team who's in charge of safety will just will have like a key phrase or something. And so the USC street medicine team out in LA uses a red pen and a yellow highlighter so that if they need to like wrap it up in a couple of minutes to get out of there, it's they'll ask somebody, oh, do you have a yellow highlighter that I can use? And if they need to just drop everything they're doing right then and there and get in the van and go, or get in the truck and go, then they'll ask for a red pen. So there are safety protocols, but I think the safest thing is that you're establishing a caring relationship with the people out on the streets, and like they're going to want to protect you. They're not going to want to hurt you.
Excellent points. Thank you. So I love that you are treating ADHD. I hear this from folks using meth a lot. Any recommendations on finding providers who are willing to prescribe stimulant ADHD medications in people who use drugs or for people who use drugs?
Um, that's a tough one. I think that it really depends. So like I suspect in like residency programs where people are kind of in like safety net hospitals or safety net programs, that people are more open to kind of that kind of treatment. I think a lot of community mental health centers that aren't aimed at, don't have education as a part of them, are probably going to be a lot less kind of up to date with some of that stuff. But there is a publication by, it was co-published by, I'm gonna get this wrong. Oh, I can't think of it. So it's the like psychiatrists who do substance use disorder care and the like primary care folks who do substance use disorder care. I'm blanking on the acronyms for those folks, but they released last year, maybe, a guide on working with people with stimulant use disorders. And it's probably like 60 pages, but it contains a wealth of information about treating those disorders, but also says you shouldn't withhold stimulant treatment based on somebody having a substance use disorder. And I think that, like, even if you have to like go in and show that to the psychiatrist and say like, hey, I've been reading this, or I stumbled upon this, I wonder, what you think of like this based on kind of updated evidence-based treatment. I think a lot of psychiatrists are going to be like, what do you know about this that I don't know? But I think some people might be really open to learning, and just need a little bit of like, I find oftentimes I'm just giving people permission to treat to treat ADHD with what they know how to treat it.
Excellent. Thank you. What is contingency management in a substance use context?
So contingency management is kind of the like new as of like 5 years ago, or but still the newer exciting kind of treatment for substance use disorders that's most often used with I think stimulant use disorders, particularly methamphetamine. But essentially you're paying people not to use, and there's pretty good evidence behind it. So whether it's like bus tickets or grocery store vouchers or like things like that, or just cash, gift cards, whatever, you're paying people to not have cocaine or methamphetamine in their urine. It's a lot harder for people who don't have the goal of quitting. It's a lot harder to use contingency management because like you can determine the quantity of those substances in somebody's urine, but it's a send out test. So you won't know right then and there if they've just reduced the amount that they're using by doing a like urine dipstick. So that's what makes it a little bit challenging when the goal isn't sobriety.
Thank you. Do we have any leverage in preventing encampment suites for people who are medically fragile and should not be moved due to health risk?
Yes. And I think it's state by state, but it may even be county or city by. I'm not sure what the authority entity is on that, but I know a friend of mine who is on the board of the Street Medicine Institute and who slept rough for 7 years in the San Francisco Bay Area. She has done so much advocacy in terms of making sure that enough advanced warning is posted for people to know when they have to leave their encampment. And then also to get a sweep to be stopped kind of mid sweep if they didn't do the appropriate things based on like the Americans with Disabilities Act. I don't know all the details for it, but I would kind of look that up. And you can also on the last slide I put the info at Street Medicine email account, and you could send a message asking that question, and it would probably get directed to it's Melissa Moore, who's on our board.
Thank you. Going back to the resources on that last slide, we are going to send out the presentation, but I did see something in the comments where someone was having issues with the QR code to pull up. Are the links to the websites there as well, or is it specifically on the connected to the QR code?
It should be connected to the QR code. I made those QR codes like well over a month ago, so I don't know. I didn't check them today to see if anything was broken, but you can Google all of those things.
Absolutely.
A lot of it is on the Street Medicine Institute website. If you're looking for that echo, that's on the Street Medicine Institute website. If you're looking for the Street Mental Health Coalition, I don't know that that's on the website, but you could just email me. And then um, there was, oh, the code for the book. Like if you just Google Street Mental Health Handbook Springer, you'll find the link on Springer, and then you can use that 20% off code.
Thank you. So when prescribing safe supply, do you have to consider the purity of the substance in dosing? For example, if someone thinks they use X GM of a substance on the street, but it's actually diluted and contaminated, will prescribing the same amount through safe supply pose an overdose risk?
So, I don't prescribe safe supply because I don't live in Canada, and I don't know the details of it, but you're right. There would be things that the prescriber would need to consider and talk with the person using it about it. And I know that they do all that as part of the package when they're doing that safe supply.
What do you learn? What do you do when you learn that people are diverting their films or other medications?
I mean, I want the medicine to go into the person's body who I'm treating because I know they need it. Do I worry about more people getting on buprenorphine? Like, people don't, it's like very rare that people are using buprenorphine to get high. Like, just exceedingly rare. So, in terms of the harm it would do something to somebody else, like, I'm more buprenorphine than the world, I think is great. But I would probably just have a conversation with a person that I'm working with to figure out what's going on with them, that they either don't want to take it or they want money for something else, or et cetera, et cetera. The way that we have done it in Pittsburgh is that we're always willing to give people like multiple chances to just have the buprenorphine in their body. Like just get it in there once and we won't screen again for a while. But like if somebody kind of after the fifth or sixth time doesn't have it has never had any buprenorphine in their body, and you can tell with like a send out if the buprenorphine was just dipped into the urine, like it wasn't processed by the body. um then we're going to have conversations about like, this doesn't seem to be working for you. Let's like, what can we do for a different approach kind of thing, but a very like non-stigmatizing, non-punitive, very low barrier approach to it too.
And for our last question, is it possible for people living on the street to participate in clinical research?
Um, Probably. I know that there are street medicine programs that are doing research. And but like like those are probably not those research studies are probably done by people who are already providing street medicine care in their areas, and they're finding patients they know or people that are on the street that they may not know but are sleeping on the street. I don't know of any sort of like national repository where you could refer somebody uh, to a study. But who knows? Like things are changing, and also there was last year a HRSA grant was funded for pilot studies of doing HIV care through street medicine to something like 15 or 25 different communities throughout the US. And I imagine that there will be a lot of papers published related to that. So we can hopefully look forward to that too.
Great, thank you. So, for the interest of time, we are 1 minute over, but I just want to say thank you so much, Dr. Fry. Always a pleasure to see you present, and I appreciate you joining us for our webinar series. And thank you, everyone who spent the time with us today. We just want to remind you that the link for the evaluation is in the chat. We will also send it out in tomorrow's post-webinar email, along with the recording and the slides. We hope that you will join us next month because we're going to continue this conversation with KK Asman, who is an MSN and nurse practitioner, for bridging the access in care for those experiencing homelessness. This will be on Friday, February 6th from 12 to 1 p.m. Eastern Time. The link is in the chat to register. And again, thank you, everyone, and have a lovely day and weekend.